Good morning, everybody. Today I'm going to be talking about Chapter 10 from the Sperry and colleagues book entitled Somatic Symptoms and Related Disorders. The following summary was written by several authors from the Adlerian perspective, so many of the case conceptualizations, or all of them rather, are based on the biopsychosocial Adlerian perspective. Somatic symptoms and related disorders are split up into the DSM-5 into 5 umbrella categories, which are somatic symptoms disorder, illness anxiety disorder, conversion disorder, psychological factors affecting other medical disorder, and finally factitious disorder. Overall, features of all of these conditions include an external locus of control, elevated help-seeking behavior, so seeking out medical care frequently, and a pessimistic view of self and others. To begin, we have somatic symptoms and we have somatic symptom disorder. The DSM-5 criteria include presence of one or more somatic or physical symptom which disrupts the person's life. Previously, this had to be an undiagnosed medical condition. That's no longer the case. So individuals with this condition can have a medical condition, but it's one that causes a significant amount of psychological distress. So there's like a psychosocial overlay with the medical condition, whether or not it's diagnosed. So again, excessive worry about the illness is present. Disproportional thoughts, feelings, and behaviors regarding the symptoms are also present. And usually a negative temperament and hypervigilance related to body symptoms. And as just a quick reminder again, simply having an unexplained medical condition does not warrant this diagnosis. So moving along to the illness anxiety disorder, this differs slightly because it maybe is related to a greater preoccupation with health in general. There's also an overestimation of their illness along with a lack of somatic symptoms. So whereas the somatic symptom disorder, this person really did have an actual physical thing going on, people with illness anxiety disorder either overestimate or do not have a somatic symptom going on. And then their medical assessment indicates no physical evidence of illness outside the normal range of sensation or symptoms, but the person is still stressed about their physical health. They have anxiety regarding their health and well-being, and being ill is a significant part of their identity, which is seen in many of the disorders we'll talk about today. The third condition we'll talk about today is conversion disorder. The DSM-5 criteria for this condition includes symptoms of voluntary motor function or sensory function, like weakness or paralysis in a limb, or in an arm or leg, and maybe a reduced ability to see or hear. Symptoms cannot be traced to a neurological disorder, so they have neurosymptoms, but just no physical evidence of pertaining to why they would have that. And the symptoms often coincide with a significant life stressor or trauma. So the way I kind of think of it in my mind is that their symptoms of the stress are converting into manifestations of a neurological or motor issue when there is actually no evidence that there's a neurological etiology for the problem. In terms of psychological factors affecting another medical disorder, this category is essentially when a person has a medical condition, a real medical condition, just like in the somatic symptom disorder category, but there is a large literature base to support the idea that psychological stress is a significant contributor. So diseases include like heart disease, irritable bowel syndrome, fibromyalgia, cancer, immune issues, endocrine issues, migraines, recurrent headaches. There are many types of physical illnesses that it's just an understood fact that psychological stress or distress can certainly contribute to the physical dysfunction. And last but not least is factitious disorder. This is when physical or psychological symptoms exist with or without a precipitating event or illness. So whereas in conversion disorder, The symptoms were often, not always, related to significant life change or stress or trauma. This factitious disorder is a little bit different because there may not have been a stressor, and in fact, these individuals are consciously making up or deceiving providers regarding an illness. Um, they're stating that symptoms exist when in fact there are none, but delusion must be ruled out. So they're not delusional in making these up. They're conscious of the decision to make up or deceive people about their symptoms. There's often a secondary gain, whether it be social or otherwise. The deception is usually not aimed at gaining an obvious external reward, such as in malingering, where individuals may um, be be qualify, for specific entitlement programs. In this case, the deception or the secondary gain is not like monetary or so that they can qualify for disability. There are other secondary gains. They're striving to be seen as sick, and they may also falsify the illness or injury of a pet or other family member, such as a child. So there's a secondary gain with that as well. I wanted to leave everyone with one final concept about individuals in the somatic symptom or related disorder category. Overall, they use their bodies to speak instead of their mouths. So oftentimes a history of family history and childhood of where they weren't really able to or validated to express feelings or psychological concerns, and they speak through their bodies. So it's important for clinicians to be sensitive, compassionate, and patient, not enabling, but understanding that many of these conditions are real and their physical manifestations are symbolic of psychological conflicts within. So thank you for your time.